Hello, everybody. Thank you for taking the time to listen to my talk. I'm Jennifer Tran, and I'm here to talk to you about the characteristics and outcomes of COVID-19 infection in the outpatient setting. And I hope to provide a guidance for the evaluation, management, and to provide a guide to triaging patients that present in the ambulatory setting. So, to provide some background on this project, I work as an internal medicine physician at a large tertiary care hospital in Washington, D.C., in the USA. When COVID first started appearing in our city in 2020, I was involved in evaluation and testing of patients that presented with cold or flu-like symptoms at a designated COVID clinic. At the time, there was not much information available as to the symptomatology of COVID. All we knew was that patients presented with fever, cough, and shortness of breath or hypoxia, and they could rapidly deteriorate to acute respiratory failure and have a high rate of mortality. My colleagues and I started to notice that the symptoms of COVID spanned way beyond just a typical cough, fever, and shortness of breath. So we set out on this project to begin to characterize the symptoms of COVID in the outpatient setting prior to patients becoming very ill and requiring hospitalization, and also to determine the risk factors that were associated with worse outcomes. Hence, what I'm going to tell you and present to you today is the culmination of our work in the outpatient COVID clinic in 2020. At the time of recording of this lecture, there are almost 175 million confirmed cases of COVID worldwide and over 3.7 million deaths. One of the major challenges to the initial containment of the infection prior to the widespread distribution of the vaccine was the spread of the virus through asymptomatic or mildly symptomatic individuals. It's estimated that about 30% of people that are infected do not develop symptoms and can still spread the virus. There have been estimates that between 17 to 75% of transmissions occur from asymptomatic individuals. So as we stated earlier, we now know that COVID infection has a wide range of presentations, from asymptomatic infection to respiratory failure and multi-organ dysfunction. The primary aim of this study was to characterize mild to moderate COVID infection and risk factors that were associated with hospitalization, ICU admission, and death. The secondary aim of the study was to determine the risk factors in healthcare workers amongst the various departments in the hospital. So here, we conducted a retrospective single-center cohort study of patients that were evaluated at the dedicated COVID clinic at our tertiary care urban hospital in Washington, D.C. from March 11th, 2020, which was when the COVID clinic first opened, to June 14th, 2020, when the COVID clinic closed. At the time, patients were pre-screened for symptoms prior to testing. However, patients with known exposure to COVID or were from high-risk institutions, such as healthcare workers or patients from group homes, were tested according to the CDC guidelines at the time of the encounter, which usually meant that patients that were symptomatic were tested. Not all asymptomatic patients were tested. Testing was conducted using both the nasopharyngeal and mid-determinate PCR-based nasal swabs, and a positive SARS-CoV-2 test result was used as a surrogate for COVID infection. Infection information was collected on patient demographics, occupations if they were healthcare workers, medical comorbidities, exposure to COVID-positive contacts, presenting symptoms, current medications, hospitalizations, ICU admission, and death. Symptoms were defined as mild to moderate if patients were sent home with symptomatic management and recommended for isolation after evaluation in the clinic, whereas severe disease was defined as patients that required hospitalization. We performed univariate analysis using Fisher's exact test and t-tests and defined a statistical significance cutoff of p less than 0.05. There were 2,821 patients that were evaluated in the COVID clinic and that were included in this study. 60.1% of them were female. There was known exposure to COVID in almost a third of the patients that tested positive for COVID. The majority of patients that presented to the clinic were Black or African American in ethnicity, and they comprised almost half of the patients that were evaluated. 13% were white or Caucasian, and Hispanics and Latinos accounted for about 9% of patients. 87.9% of patients that came to the clinic were actually tested for SARS-CoV-2, and a little over a third of the patients that tested were positive for COVID. The mean age of infection for patients was 43.4 years old. And although more females presented to clinic, more males ended up testing positive, with 41% of males testing positive versus 29% of females. Similarly, although there was a higher number of Black and African American patients that presented to the clinic compared to Hispanic and Latino patients, a higher proportion of Hispanic and Latino patients actually ended up testing positive for COVID compared to Blacks and African Americans. It was 71% compared to 28%. Of the total number of patients that were evaluated in the clinic, 47% were healthcare workers, and 24% of them ended up testing positive for COVID. Healthcare workers that were more likely to test positive than non-healthcare workers. And amongst healthcare workers that tested positive, the majority were registered nurses, which accounted for 23% of those who tested positive, followed by medical assistants and personal care technicians at 10%. Physicians and food service workers accounted for about 7% each for infection. Within each department in the hospital, the general medicine service had accounted for the highest proportion of healthcare workers that tested positive and accounted for almost 40% of those that were infected in healthcare workers. This was followed by the critical care units, which accounted for 14% of those with infection. Amongst patients that tested positive for COVID in the clinic, 11% required hospitalization after being evaluated. The median number of days from testing to hospitalization was 2 days, and the median length of hospital stay was 6 days. Of the 101 patients that were hospitalized, 23% required ICU admission, and 11% of them died. The overall mortality rate of patients that presented to the COVID clinic was 0.4%, and 2% amongst those that tested positive. Symptoms that were significantly associated with COVID infection included anosmia, fever, both subjective and objective, chills, change in taste, anorexia, myalgias, fatigue, malaise, and headache. There was no significant difference in the presenting vital signs of patients that were COVID positive and COVID negative. Diabetes was an associated risk factor for COVID infection in our study, and patients with diabetes were more likely to be hospitalized, whereas malignancy, asthma, and other lung diseases were less likely associated with infections. There was no significant association between medication use and COVID infection except for the use of insulin. Among patients with lung disease, COVID infection was associated with cough, ED referral, and hospitalization. In patients with malignancy and COVID, fever was an associated symptoms, and all patients with malignancy that presented with anorexia and COVID infection were hospitalized. In all, almost 1 in 3 patients that presented to the COVID clinic tested positive for SARS-CoV-2. 88% presented with mild to moderate disease, and 11% developed severe disease requiring hospitalization. The ethnic and racial distribution of patients that presented to the clinic mirrored that of the surrounding demographic area of the hospital in Washington, D.C. However, the finding of increased COVID positivity in the Hispanic population is concordant with other studies performed in the United States and is likely due to socioeconomic factors and crowded living conditions due to high cost of living in the metropolitan area, but it also highlights the racial disparities associated with COVID-19 infection. Our data suggests that patients with severe disease were more likely to decompensate and become hospitalized within 2 days of presenting for testing. In those that presented with severe disease, 23% required ICU admission and 11% died. Overall, this counted for 1.2% of patients that tested positive in the outpatient setting. This suggests a broad gap in presentation in those who are mildly symptomatic or asymptomatic and those who are very ill, with the majority of patients being mildly symptomatic, and they remained ambulatory. Interestingly, shortness of breath was not an associated presenting characteristic of COVID in this study, and it may be due to the fact that these patients presented directly to the ED instead of to an outpatient clinic. Occupations that tended to have higher rates of infection were occupations that had frequent close proximity contact with patients, such as registered nurses and personal care technicians. Since most COVID patients are cared for on the medical units, the general medicine floors accordingly had the highest rates of infection, followed by the ICU. Although patients with COVID in the ICU had a higher acuity and suspected higher viral load, it's suspected that there was less transmission to healthcare workers due to the presence of negative pressure rooms and the use of PPE, because patients in the ICU were already usually identified as being COVID positive or being under investigation, so adequate use of PPE was in place. Patients with comorbidities of lung disease and cancer were not associated with increased risk of infection in our study. And this could be due to the fact that these patients were more vigilant about their symptoms and more adherent to social distancing and mask wearing. And if symptomatic, they may have presented directly to the ED instead of into the clinic. Strengths of the study include the large sample size and ability to track patients across the outpatient and inpatient setting using the electronic health record system and the information exchange system, which was established between neighboring states. Limitations was that it was a single site study, so results may not be generalizable to other sites and populations of different demographics. Another limitation is the inability to test all patients that came in for evaluation. So we could have missed some asymptomatic infections. However, testing at the time was performed according to the CDC recommendations, and this was usually due to supply limitations and available knowledge. Overall, based on the results of the study, we found that patients that were 45 and older with known exposure to COVID, healthcare workers, and diabetics were at higher risk of worse outcomes from COVID infection, and they should be given early recommendations for testing and available treatment. Patients presenting with anosmia, fever, chills, change in taste, anorexia, myalgias, cough, and fatigue should be assumed to be COVID positive until proven otherwise. And this information we hope will help clinicians to provide a targeted review of systems and evaluation of comorbidities and allow for the appropriate patient triage and counseling and referral to the appropriate treatment modalities. That is it for my talk. I hope that this was helpful and that you could take some information back with you in the evaluation of your patients. I hope that everybody has a great day and enjoys the rest of the conference. Thank you.